of the provincial child health service. There are some people who should mute their microphones, please. I'll introduce them in turn, and I'll do the introductions very briefly for the sake of trying to get through the presentation. Firstly, Rene Nassen. Rene is fairly well known, at least to some of us. She is a UCT graduate who, like many of our colleagues, have moved across to our friendly neighbors, the University of Stellenbosch, where she currently is an academic. She's had a fairly peripatetic career in child psychiatry from the old days at DCAP at Red Cross, and then moved across to Tygerberg Hospital Child Services, and is currently the head of the CAMS unit at Lenterhill Hospital. And today she'll be speaking with us in her capacity as the coordinator for CAMS services in the province. And then Stella Mokitimi, who, very similar to Rene, has been around for a very long time. I won't say exactly how long for the sake of saving any reference to her age, but I know Stella from a very long time ago when she worked at Falkenberg and then moved on to Red Cross DCAP, and is currently working in the Khayelitsha Eastern Sub-District as a mental health coordinator. Stella is a nurse practitioner who also has a PhD from UCT, and much of her research is focused on the topic we're speaking about today, which is CAMS strengthening, particularly in resource-constrained settings such as ours. And then finally, Dr. Simphiwe Simelane, whom I discovered today I also know from having taught her at some point, she says. She's a medical practitioner with experience both of work in the urban as well as the rural setting, and was currently a PhD candidate in our department. Her research employs an implementation science framework directed at developing a functional integrated mental health service for children and adolescents in South Africa. So thank you very much to our presenters. I'm going to hand over, I think, to Rene, who will take over. Thanks.
Thank you, Peter. And on that note, the slides are not moving. Oh my goodness. Sorry, I'm struggling to get the slides. There we go. So thank you very much for the invitation to present to us, to all of you. We have come a long way over the many years of advocating for improved mental health services for children. Today, let's pause to celebrate the opportunity afforded us to strengthen CAMS services. May we resolve to bring fresh eyes and energy like that portrayed by these children to the task going forward. Just a brief presentation outline. We are bringing together different perspectives in a single presentation from CAMS, from Stella in her capacity as CAMS mental health coordinator and implementer of her recent research. Myself in my role as a coordinator to task, with a task to collate, engage, and implement, and to do an implementation framework. And then, of course, Simphiwe as from the research perspective. We are presenting and sharing the broad aims and preliminary plans. So bear with us, this is a start. We do not have a blueprint to encompass a very big picture view yet. So this is an invitation for contribution, for potential collaborations, and to support us as we move out of the starting blocks. Over to you, Stella.
Sorry, I was muted. Thank you so much, Rene, for that introduction. I'm basically going to provide the context, a picture of the context in which this strengthening project is going to take place. Next slide. I'm sure we all know that the mental health problems are the greatest health concern among children and young people compared to all other health problems. And if no attention is given to them, as we can see in this figure, they definitely progress into adulthood. Next. Next slide.
Sorry, I'm just struggling to get the slides to move, Stella. Okay, go ahead.
You can move to the next one. Is it not moving, Rene?
Yes, I am moving it, Stella.
Okay, it hasn't moved on my side.
My goodness. Here we are.
Okay, do you want to go to the previous? It hasn't moved on my side. It's still the figure that I'm seeing.
Is everybody else seeing that I'm moving the slides?
No.
No, it's not working.
Oh dear. Okay, I'm going to try to share again.
Okay.
I'm sorry about that. And share the screen. Is that fine? Are you seeing that?
I can see it
see
now,
the screen?
Rene.
Is that fine?
Yes, all right.
Okay.
So just to continue, so we all know also that about 1 in 5 children and adolescents, they suffer from mental illness globally. And in the low and middle income countries, we get more children and adolescents. And again, the rate of unmet need is huge, where the resources for child and adolescent mental health services are lacking. And those that are available are actually unresponsive to the needs of children and adolescents. And this tells us that we need to strengthen child and adolescent mental health services, including our context. The next one. So in my study, we wanted to get an in-depth understanding of the current picture and the current state of child and adolescent mental health services in our local context in the Western Cape and also at national level. So to do that, we developed this multi-level synthesis model that we also used to look at all the aspects of the service. We started by looking at the policy landscape, trying to understand the availability of standalone child and adolescent mental health policies in all the 9 provinces of South Africa. And then from there, we moved to look at the resource landscape. We wanted to understand the resources that are available in the Western Cape for children and adolescents with mental health problems. So we conducted a situational analysis there. And then we moved to explore the perspectives of all the key stakeholders in the service, starting from the senior stakeholders to the grassroots level users and providers. Next one. The findings of these situational analysis, policy analysis, and the user and provider perspectives, you're definitely going to find them from these papers, as you can see. Let's move to the next one. So I'm going to summarize the key findings from our study in the Western Cape. We found both negative and positive findings. I'm going to start with the positive. The 3 main positive things that we found about child and adolescent mental health services in the Western Cape were that, as we know, we've got 3 child and adolescent mental health specialist units, which are the pillars of the service. We also found that in some facilities, there were grassroots level service providers who were doing innovations such that they were able to provide child and adolescent mental health services that were responsive to the needs of children and adolescents with mental health problems, regardless of all the challenges that we're encountering. The other positive finding was that the specialist, child and adolescent mental health specialists, the Department of Health and pediatricians were starting to collaborate at the time. As you can see, the whole list of the negative findings actually showing the weaknesses and the threats to child and adolescent mental health services. At national level, none of the provinces had developed child and adolescent mental health policies, not even implementation plans to give effect to the national policy. Coming to our context in the Western Cape, there was no dedicated financing for child and adolescent mental health services. The resources were lacking, and the little available resources were inequitably distributed across our province. The three main departments that are working with children and adolescents were not collaborating. They were basically working in silos. Within the three specialist child and adolescent mental health units, there was lack of uniformity and consistency in the manner in which they were working. There was lack of support and acknowledgement for staff and negative staff attitudes towards child and adolescent mental health services, preventing them from even attempting to provide responsive services. The provision for medication for children and adolescents was variable and inconsistent across the health facilities. Psychosocial interventions at primary and secondary level, they were limited. The information systems for child and adolescent mental health was inadequate, where we find a lack of disaggregated data to inform planning for child and adolescent mental health. Training, public education, and research were also very limited. Next one. So as we can see from these findings, we find a lot of weaknesses and threats. And the tipping point scale here, we can see it shows that if no attention is given to child and adolescent mental health services, they will definitely fall apart. Next one. I'm going to summarize the key recommendations as we engaged with the service users and service providers. We also asked them about what they would like the services to look like. What recommendations would they come up with for us to be able to strengthen the service? And now I'm going to summarize those key recommendations. We came up with recommendations for policy development, for service development, for training, and for research. Now for policy development, we recommended a review of the National Child and Adolescent Mental Health Policy to make sure that it is fit for purpose. We also recommended an appointment of the Provincial Child and Adolescent Mental Health Lead who would coordinate child and adolescent mental health services within the province and also facilitate the incorporation of research findings into policy development and implementation. Once those policies are in place, we recommended that they should be made publicly available. We also recommended a redesign of child and adolescent mental health services across all levels of care and in urban and rural areas, and also an establishment of child and adolescent mental health teams that would support inpatient and outpatient services. For training, we recommended that training should be provided in all disciplines across all sectors, again, in collaboration with the academic institutions, and also public awareness works on camps to be supported. And lastly, for research, we recommended that researchers, government policymakers, and all other stakeholder groups should develop research priorities for child and adolescent mental health services. We are very excited that we were able to generate evidence from our local context and giving the current picture of the current state of child and adolescent mental health services in our Western Cape province. And we hope that all this data and all these findings and recommendations will add value to the strengthening project as will be presented by Dr. Nassen. Thank you.
Thank you, Stella. And so in preparation of sharing some aspects of the CAM Strengthening Project, I thought I should give you a bit of a historical look back to the past 6 years, when in 2016, there were more regular engagements with senior management about the state of CAM services. And following that, there was a request for the 3 CAM service heads to conduct and present a rapid appraisal of CAM services, which was then presented to senior management. And then a few years later, a CAM service plan was developed and presented, where there were a couple of recommendations, 2 of which was that that we recommended dedicated child mental health nurses on the district platform, and a review of governance, including a role for a CAMS coordinator. And then there were further developments into the COVID era, where there was quite a significant spike in pressures in CAMS brought about by COVID and all of the stresses related to that. And then in 2021, following the retirement of the 2 CAMS heads, Dr. Vogel and Dr. Hawkridge, there was an opportunity to review and reflect on the roles of these posts, and to then begin with a proposal for a role of a CAM coordinator. During that time, a couple of months later, in August last year, there was a theory of change process that was led by our public health, mental health specialists. And following that, a more extensive proposal with costing was submitted. However, in early 2022, we were given feedback about the budget that has been apportioned to CAMS, and so a revised proposal was submitted in discussion with the now heads of clinical units and Professor De Vries, and following that, a proposal for a CAMS strengthening project. I think it's important in support of Stella and her sharing her research to say that over the years, we have slowly been building a research capacity within CAMS, with Stella's CAMS strengthening PhD and a second one underway. And of course, the work of our previous colleagues, like the late Professor Alan Fletcher, and the work of Professor De Vries, and of course, Mark Tomlinson at Stellenbosch University will hopefully contribute to this interface that we are trying to build. So this is also a call and a request for any interested parties to collaborate with us in terms of research. In terms of my role and key outputs, and this was fleshed out during many meetings, and there is a document that describes this, but essentially it was, at least initially, to make and formalize linkages with other disciplines such as pediatrics and child health, and to set myself the task of strengthening the interface between health and the other sectors, and of course to look for opportunities within the NPO sector for collaborations. And following that, the thought then was about what would be the most affordable and achievable approach to strengthen mental health services in the Western Cape, and considering the budget that has been, or the funding that has been provided. And before we speak about the project, I think it's important to pause and to reflect on the challenges that we are facing, at least in the health sector. And we are all aware of many of these, and we are aware of the CAMS pressures and risks, particularly the bed pressure risks, the risk in terms of the safety of hospitalized adolescents admitted to emergency unit. We are also aware that currently CAMS is located at tertiary subspecialty level, and so there isn't a even spread of expertise across the platform. And it is vital that we support the district teams, particularly to build a co-collaboration on the primary platform, but also in relation to the pressures to collectively create a more effective tracking, surveillance, and clinical risk management system so that we can manage our risk more effectively. And then, of course, to collectively set ourselves the task to improve the system's coordination, to work in more integrated ways, and to really effectively utilize the capacity that we do have on the system. And I do believe that there is more than what we realize. And of course, not to forget our very high-risk populations that we have to manage from day to day. From a systems point of view and from an intersectoral point of view, we've mentioned the intersectoral gaps, and there are many, and really we are moving towards agreements to improve our networking and coordination. We have a skills deficit across the board, and this unfortunately really impacts on that interface where the mandate of health ends and that of education and social development begins. And so unfortunately the boundaries are blurred, and this results in problems related to the referral route and pathways. And so over to the CAM strengthening project. I'm sure you are all aware of the budget that was apportioned to CAMs. It's not a huge amount. It's an amount of 6 million. And with that, we believe that it was a start and to set us in the direction of moving forward. We have decided that we are going to focus on 2 areas. And the first would be to really attend to what is creating the biggest pressure. And that is the issue of the adolescent inpatient beds. And a decision then was that we should look at whether we could increase tertiary bed capacity on the platform, and also to dedicate ourselves to safeguarding children and adolescents in district hospitals. And in that regard, and without having the time to go into too great detail, myself and Stella have started with that in the CARES environment. And then in terms of the strengthening of the primary platform, in the absence of funding to appoint people to perform operations, we've had to take a system strengthening and strategic approach, and it will focus on aspects related to service design and the activities of CAM on the primary platform. And this activity certainly will be benefited by working alongside the CARES mental health coordinator, as Stella has already collated good data. She's already established dedicated CAM clinic days in CARES and has established a interface with managers and so forth. And so quickly around the adolescent beds, there is an acknowledgement that the need for dedicated adolescent beds is on the West Metro platform. But with the limitations of the budget, it has been decided that we are going to have to use existing infrastructure. And that meant that it has been decided that we will extend the current acute unit at Lentegeur Hospital and at the place where I work. And unfortunately, the funding will only allow an increase of capacity by 10 beds. But in terms of the layout, we will be able to bring some beds onto a separate wing so that we can provide a safer space for females who are admitted to the acute unit. We are well on our way to commissioning this unit, and we are waiting final feedback from engineering work so that minor innovations can start. But throughout this time, I've wondered if this is the solution, considering the real increase in the burden of disease, and considering that the expectation that all adolescents could potentially be transferred or admitted on the tertiary platform. We are not doing ourselves any favors in terms of strengthening district capacity to manage some of these adolescents. We also should acknowledge that all adolescents admitted are not really, it's not necessary for them to be managed within a tertiary space. And so also to share that there are significant challenges to maintaining the flow of patients on the tertiary platform. For example, we have a significant amount of children who await placement for months on end. And unfortunately, one of our adolescent units also fulfills a district function. So my fear is that we likely will reach saturation quite soon with a call for more beds to be commissioned with a repeat of the current impasse. So moving to the primary CAMS strengthening project, the submission that was put forward was to create a team who will be appointed on a part-time basis to fulfill particular functions. In terms of the core functions, individuals will look at aspects related to packages of care, designing a more robust CAMS training platform, and also a psychological framework for CAMS, and also the design and implementation, hopefully, of a prevention and early intervention project. Unfortunately, funding for someone to perform a liaison and communications function and to be kind of looking at data, we have not been able to appoint such a person. Over to you, Simphiwe. And Simphiwe has been appointed to be on our CAMS team on a very part-time basis, but it's really quite exciting because in terms of how we can move forward, we have a researcher who is going to be working closely beside us. So over to you, Simphiwe.
Thank you, Rene. Good afternoon, everyone. My name is Simphiwe Simelane, as Rene has said, and I'm currently doing my PhD at the Center for Autism Research in Africa in the Department of Psychiatry at UCT under the supervision of Professor Petrus de Vries. My broad PhD topic is on strengthening CAMS at the primary care level, and this project presents a unique opportunity to link the research that I'm doing with practice. It's widely accepted that the lag time for research evidence to reach clinical practice is 17 years. So there's a big push towards research approaches that include planning for implementation and dissemination from the outset. The PhD doesn't cover all aspects of the project, but it is complementary to some of the objectives. Next slide. A key element of this project of this project is ensuring that the planning and implementation process is participatory throughout. This is to ensure that there's buy-in of the stakeholders who will be integral to ensuring that anything that's developed is successful, and that the project therefore needs to be participatory and patient-centered, including looking at how patients and caregivers can be involved in the process. It needs to be evidence-informed, and it needs to aim to strengthen continuity of care. Next slide. The objectives of my arm of the project are to establish packages of care for CAMS at primary care, to determine core competencies for primary care, to develop tools to assist with the assessment, management, and monitoring of patients at the primary care level, to develop and outline clear referral pathways, and to try and see how we can use data capturing tools to improve evaluation and monitoring of the process and of clinical outcomes. Next slide. So according to the Western Cape Department of Health, packages of care define the services that are offered at each level of care. And they do this by identifying clinical conditions and procedures that are appropriate for each level of care. The lists aren't exhaustive, but it provides a framework for us to understand how services should be structured. So this slide is just an example of the disparity between packages of care outlined in other priority areas compared to in child and adolescent mental health. So in 2009, the Western Cape government produced a document called the Acute Hospital Packages of Care. And if you look at the document, the pediatrics has an extensive list of conditions that should be managed at primary care level, which provides clarity. So this goes on for 5 pages. It's divided according to levels of care, and it's divided according to specialities as well. If you look at the CAM section, or the child and adolescent mental health section, there's no description or list of conditions for level 1, and this only starts from level 2. It also, for pediatrics, lists specific competencies and equipment required to carry out these procedures and to look after these conditions. And for CAMs, there's no specific list of competencies and equipment required, although this is provided for general psychiatry. Next slide. This is a busy or small slide, but it's just to illustrate what I mean. So if you look on the right, if you look on the left-hand side, that is what it looks like for pediatrics. And this is just a small section of the first page. And if you look on the right, you see what is available for CAMs at primary care level. And this is all that's written there. Can you move to the next slide? Thank you. So in terms of clinical guidelines and toolkits, next slide, Rene, thanks. The Western Cape government or Western Cape Department of Health, in line with national policy and strategy, wants to move towards an integrated approach where mental health is increasingly decentralized and managed at the primary care setting. But if we look at the national primary healthcare standard treatment guidelines, there is no guidance for the evaluation and management of child and adolescent mental health conditions. There's only some detail that's given about the management of the aggressive child or adolescent, but in terms of all other conditions, the guideline states that all children should be referred to secondary level. And that means that there's an obvious gap where there are no guidelines for mental health nurse practitioners, medical officers, and family physicians on management of patients with established or diagnosed mental disorders at the primary care level. Next slide. Okay. So there are existing documents outlining referral pathways, but we need to consolidate these and ensure that once we have clarity around packages of care, the referral pathways also reflect these. And we also want to try and see if we can use digital data capturing tools to try and improve the way that information systems in CAMs are working. Next slide. Thank you. The research approach that we're going to use to guide this process is a dissemination and implementation science approach. And this current project timeline only allows for the pre-implementation and piloting phases. But our research approach also allows us to plan for implementation and dissemination. In the pre-implementation or planning phase, we'll engage stakeholders, understand existing evidence, identify barriers and enablers to delivering care, select implementation strategies, and develop a theory of change map for how we will proceed with the project. And then in the piloting phase, we'll pilot these implementation strategies and refine the theory of change map. Okay, next slide. So if we look at what's already been done, we've already started engaging stakeholders from the outset. So all the research that has been done to date has been participatory, with engagement of various levels of stakeholders using focus groups, semi-structured interviews, surveys, and the theory of change process. And we've also started to try and understand the existing evidence. So through Stella's PhD, we've got an understanding of the background work, and we've also published a review of health system strengthening activities that are happening in other low and middle income countries. We've done a desktop review of all resources that are currently being used for clinical services in the Western Cape. And we've started to identify potential evidence-based tools that can be used in order to strengthen CAMs. And that includes, for example, using MHGAP, the intervention guide, to try and develop these clinical tools or to inform them. Another example is using the collaborative care model to try and form the strategy around which we will deliver care at primary care settings. So these are just examples of tools that have been identified, but through a stakeholder engagement process, we'll identify what's the best fit for our setting. Next slide. Okay, so what still needs to be done? So we need to have ongoing stakeholder engagement. We'll need to identify barriers and enablers of delivering care at the moment in our setting. And this has been done, for example, through Stella and Rene's site visits. It will be done through interviewing service providers on what's currently going on, and through file review processes. And then we need to identify enablers and barriers of potential evidence-based practices, as I've previously mentioned. We'll need to develop a theory of change map, which shows how the objectives, how achieving the objectives that have been listed will actually end up strengthening CAMS at the primary care level. And the outputs of this will be partly the packages of care, the referral pathways, everything that I've previously mentioned. And then as we pilot the project, we'll have to refine that map and that pathway and see if we need to adapt our implementation strategies as well. Thank you.
Right, and so thank you, Simphiwe, and a few last slides. And so at a systems level going forward, we have a sense of what we have to do and where we have to do it. And so to start off with, I think it's going to be important to define what the CAMS platform is and where it is, of course, because it's not just the acute and severe end and not just what sits on the tertiary end. It's also those children who have been receiving psychological and psychosocial services over the many years, unfortunately in multiple spaces which are not very well coordinated and are unrelated to each other. But it is also important that we define competencies for pediatric primary clinicians as stated in the American Academy of Pediatrics. And these include communication, promotion and prevention skills, evidence-based assessment, psychosocial and psychopharmacological skills, and most importantly, team-based skills. So our intention moving forward is that we will move towards a design for a CAMS governance framework and hopefully a CAMS service delivery framework across the levels of care, with a reference to an incorporation of local CAMS strengthening and other local research, but also with reference to other models, such as the collaborative care model, and to be overtly cross-disciplinary and multidisciplinary in our approach, to be consultative and responsive, of course, and flexible to the local context. In terms of how we will start, recognizing the size and scope of what we are about to embark on, it has been sensible of us to decide that we start somewhere small in a learning site or a so-called pilot site. It has been decided after discussions with the director and substructure managers of CARES that it will be in the CARES area. But coupled with that, we have also started discussions on the West Metro platform for starting with strengthening our psychological framework. And I am involved in a small little activity where we are testing an activity where myself and a pediatrician and a district psychiatrist can co-manage a shared patient population. And of course, in going forward, we need to map who our partners are and who the experts are that we will be consulting, and most importantly to who are our advocacy partners. And for that, just one mention, very grateful to the interest of the Commissioner for Children, Christina Namdu, and her office in supporting us in our work. The area that has been chosen is Macassar, which is an area rich with history. And in terms of moving forward, we hope to finalize a memorandum of understanding so that we can start site visits and engagement with staff and the mapping process of what services exist and meeting teams. hopefully over the next few years, we will be able to define a vision for CAMS and a 5-year plan where we can actually collate all of the priorities as I've set out on the left side. I won't go into it in detail, and also then moving towards a more vertical model for governance in terms and defining how we will relate to each other in a more collaborative way across the levels of care. In terms of next steps, there have been many engagements on the district platform, and these engagements will continue. The CAMS strengthening appointments have happened or are about to happen in the next day or two. And in that regard, a roadmap and a description in terms of an initial action plan has been submitted to the health managers. And of course, we hope to initiate the pilot project soon. I'm hoping too that we will be able to engage with information management so that we can put a data tracking system in place. And I'm very pleased to report that there have been some good discussions with local NPOs that have been doing work with children and adolescents. I appeal again for any potential research collaborations, and we will continue to engage with the experts and with our CAMS colleagues, and will provide feedback to the Evidence-Based Advisory Committee. In terms of a pilot, I'm hoping that we can decide on a pilot site in the next year, once we have gone a little bit along the way in terms of our metro pilot. This is just a timeline of the activities of the primary healthcare team as they start. Just in terms of a final conclusion and reflection, some of you may be asking whether we are building a house on a shaky foundation. And the answer is yes or no, and no. Yes, because there is much to do to strengthen the collaborations and to repair our systems. But no, because CAMS has come to the attention of many, there is a collective commitment to improve the services. And also there is a lot that is happening that is invisible that we need to bring to the front. And as I said, we need to maximize existing resources. We have some work to do around looking at the culture and the way in which we engage with each other to achieve buy-in. But I am most excited by the opportunity for an interface between clinician leadership and best practice and research findings and experts. Just as a final and more personal reflection, I often think, when I think of this task and all the moving parts, I think in either musical or artistic terms, and I think of this as a task to commission an orchestra or a choir and then to make music together. And when I thought of this recently, a song came to mind by the Beatles, and the title is "I'm Fixing a Hole Where the Rain Gets In and Stops My Mind from Wandering. I'm filling cracks that ran through the door, but it really doesn't matter if I'm wrong or right. Where I belong, I'm right. Where I belong, I'm right." And on that note, I want to acknowledge the many people before me and the people with me who are going to walk this road. There have been many who have done much to support us so that we can start on a good step. And so I thank you all. And if time allows, after the discussion, maybe we can play the song. Thank you very much.
Thank you very much, Rene and Simphiwe and Stella. The wonderful and somewhat uplifting moment in what often is a sea of misfortune. And I think for most of us, we wish you and your team well. There may well, and you've presented this, a lot of complex information very crisply, and so you've left good time for a few questions. So I'm going to watch for reactions from our audience. There have been some comments. There may be others who might want to respond. Elmarie, I've noticed your hand.
Thank you very much. Can you hear me?
Yes.
Oh, good. Just wanted to congratulate Rene. I was part of, in part, a earpiece for her at times as the sort of former general pediatric oversight person. And I think it's just very exciting that we've got this far. I had a question about prevention, and I know she mentioned it in towards the end in relation to equipping pediatricians, but perhaps just to allow her an opportunity to talk a little bit more about the preventive and promotive aspects, if possible, please. Thanks.
Yes, sure, Henri. So what we have been thinking of initially, of course, is to look at the so-called low-hanging fruit, so to speak. And the first would be to look at the infant mental health space and whether we could start a project for the 0 to 3s, whether it's with infants or maternal mental health and so forth. And so we certainly are going to start engagements with Dr. Latchman, and Teresa Whitaker will be leading that after a literature review where we will be looking at prevention and early intervention projects. Then we will choose a project in the 0 to 3 age group. But a second area that we have decided to focus on is a substance prevention and wellness project, which my colleague Benny Steyn has been very involved in and spearheading in our neck of the woods. This is an Icelandic project that has spread across the world in high and lower middle income settings with great success. And there has been a plan to expand the pilot from the wilderness area from George, possibly to Mitchell's Plain, but we've also been looking at other areas. And Benny has done quite a lot of work in that regard, and hopefully we will be able to present something soon. The third area has been following our discussions with our West Metro colleagues, and the only dedicated CAMS psychologist, JP Hartman, I hope I remember your surname correctly, JP, if you are here. And we had a rich discussion with the colleagues there, and really what seems to be an opportunity too for earlier intervention is to actually enter the child health clinic space and to look at whether there are opportunities there for screening and for early interventions like parenting and supports to reverse the trend that we have at the moment, and that is that children become symptomatic and it's only years later that they actually get a sense within a mental health space. So it's early days, Elmarie, but those are the thoughts. And in terms of the third plan, I have already made contact with our pediatric colleagues so that we can try to include this in the pilot in Makassar.
Rene, there's a question from one of our forensic psychologists about referrals of children in conflict with the law and the whole issue around child justice. Is there any way in which this is addressed in your plans, or any thoughts about taking that forward?
Unfortunately, we really have to be quite generic, and we hope to be able to identify the high risk kind of situations. And thank you for raising this and with a dedicated plan, but not immediately, I'm afraid. And there is an acknowledgement that we've lost some capacity there, because our colleague, Dr. Hawkridge, was regularly involved in providing support and input. I'm very open to just taking this discussion further, though, outside of the meeting. So maybe if I could be contacted, and then we could have a sit down and look at how we could incorporate this. Thank you.
There's another question from Berenice Daniels.
I'm not seeing the question. If you can just read it, or if
Berenice has got a hand.
Hi, Berenice.
Hi, Rene. Thank you very much to you and your colleagues for a most interesting and enlightening presentation. It's early days, but we as the Department of Education are looking forward to increasing collaboration with our Department of Health partners. And we've already begun conversations about that. And this happened at a time when at the level of the province, there's an interdepartmental mental health task team under the leadership of Dr. Keith Clitty that has been established, which is really putting all of these issues onto the radar. And just to say, for those who don't know, a little task team, sub-task team has been established on a theory of change. There's an evidence-based committee, data alignment committee, social mobilization subcommittee. And we're looking at a three-tiered approach. What can we do in early intervention and prevention? What we do at a more of a consultancy level, and then with the individual child and young person. And just also to say, in the Western Cape Education Department, the priorities for 2022, there are three, and one of them is increasing well-being and psychosocial support services. So it looks like everything is coming together, becoming aligned, and then also with early childhood development coming over to the Department of Education, there are more possibilities. So it's been a long journey in rather arid lands, but I think we're reaching the fertile ground now. Thank you.
Thank you. Thank you very much.
I'm just wondering, we're coming towards the end, if there was any further comment that either Simphiwe or Stella wants to make in relation to some of the questions that have been asked, or some of the comments in the comment list. So Stella or Simphiwe?
I think from my side, it's just that, again, it's early stages, and we're sort of going through a dual processes. There's some stuff that we're still trying to figure out, some stuff that we're still mapping, and then there's other things that we have already been mapped and are moving into a point of strengthening, or actually now developing projects. So I think if anyone is linked and has some input or some idea, I think definitely just be in contact, and actually do make contact with us. Please don't just say you will. And then we can try and see, because as Berenice told us now about what's happening in education, there are a lot of things that are happening, and we all need to actually be aware of what everyone is doing, so that we don't reinvent the wheel, and we can start to actually work together better.
Thank you so much. That's just to add on what Simphiwe and Rene has already said. I mean, this is an exciting time for this strengthening. We already know, we've heard about the gaps, and that there is so much to be done on the ground. And it's also exciting, I think, what I'm also looking at and seeing, put on the chart in terms of other projects, strengthening projects that are happening in other areas. This is exactly what we found in our study, that when these things are not out there, it seems that, nothing is happening. So it's going to be exciting to uncover, all those strengthening innovations and integrating them into the projects. Thank you.
Thank you very much. I don't see any further hands. And so perhaps just to say that there have been several very positive comments, and I think everyone's caught up in some midwinter excitement about what lies in prospect as we approach spring. You managed your time very well. And so after just thanking you on behalf of all of us for this great presentation, perhaps you can be indulged to your child's psychiatry moment of playing your song.
Thank you.
Thank you very much.
We'd love that. So, I think it's only a minute, so just give me a moment and I'll go to the last slide. And as you say, indulge ourselves to this moment. Thank you. On that note, thank you, everybody.
Thank you very much.
Bye.
Thank you.
And I hope to see many of you again for our next lecture at the end of August. Thank you very much. Good afternoon.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye.
Bye.